Hi everyone, it's Jess. This is my presentation about schizophrenic spectrum and other psychotic disorders. I hope you guys are all doing well with this whole coronavirus thing. It's pretty crazy right now at work and with school online and everything like that, so I hope everyone's doing some self-care. So let's hop right into this. So covered in my presentation, there will be some disorders that we'll go over, including brief psychotic disorder, schizophrenia form disorder, schizophrenia, schizoaffective disorder, catatonia, other specified, and of course we'll go over the case study of John Evans. So what exactly is schizophrenia spectrum and other psychotic disorders? They're defined by abnormalities in one of more of the following: delusions, which is typically when someone thinks something is happening but it really isn't. For example, if someone thinks that the FBI is coming to get them. Hallucinations would be, it could be auditory or visual, seeing things that aren't there, hearing voices, hearing other things that aren't actually there but in your mind. And then disorganized thinking. This is characterized by having disjointed thoughts, sudden stopping in your thought process, random words that you're speaking. Often it can be incoherence. Often people with these disorders can experience abnormal motor behaviors, also known as catatonia, and this can be characterized as having abnormal postures or movements. Sometimes people can become agitated or just have strange movements in general. And then often people experience negative symptoms. And yes, I know negative is kind of harsh, but that's what they call it. So during this, it could be inexpressive faces, blank stares, monotone speech, very few gestures, so they're just kind of blank all over. The inability to feel pleasure, do things that they like doing or had used to do. A flat affect, which they don't show any emotions. Yeah. And it's said that about 25% of people with these disorders have this condition called defect syndrome, which is defined by severe and persistent negative symptoms. So the first disorder that I'm going to talk about is brief psychotic disorder. And I must say that I have not actually heard of this disorder until obviously taking this class. I found it pretty interesting. So it's the sudden onset of symptoms, non-psychotic state, and then going from that to the psychotic state within 2 weeks. So it's the brief. And then the diagnostic criteria as shown in the DSM-5. Criteria A is the presence of one or more, and at least one has to be on 1, 2, or 3 of these. So delusions, hallucinations, organized speech, and then grossly disorganized and catatonic behavior. So it has to at least be one of delusion, hallucinations, or disorganized speech in order to meet the criteria for A. And then criteria B, at least 1 day, but less than 1 month. And then the person would return to their normal level of functioning, so their baseline. And then criteria C, the disturbance is not better explained by major depressive disorder or bipolar disorder with psychotic features or any other psychotic disorder. So again, brief psychotic disorder would be characterized, in a nutshell, a brief psychotic episode. So some of the specifiers of the brief psychotic disorder would be with marked stressors. So according to the DSM-5 on page 94, the stressors would be symptoms that occur in response to events that would be very stressful for anyone in a similar circumstance in that person's culture. And then you would specify if it was without the marked stressors. You would also want to specify if it was with postpartum onset. So if it's during pregnancy or within 4 weeks of giving birth. And then you would want to also specify if it's with catatonia. And with this disorder, you're also able to specify the severity, but it does say that you do not have to do this in order to give the diagnosis. So the severity would be rated in a quantitative assessment, and this would be on a 5-point scale, ranging from 0 to symptoms not being present to 4 being present and severe. People with this disorder typically experience emotional distress and become overwhelmed and confused. Even though this is brief, it can cause severe impairment, so it is recommended that if someone is very severe with this, that they be supervised to make sure they are properly taking care of themselves, not hurting anyone or themselves, eating, sleeping, etc. It's said that in the United States, this disorder may account for 9% of cases of first onset psychosis, and this is on page 95 of the DSM-5. Often, this disorder can be related to pre-existing personality disorders and traits, such as borderline personality disorder. Some of the cultural aspects of this is just to remember that in some cultures it is normal for people to experience hallucinations, and during like ceremonies of religiousness, it's perfectly normal for them to hear voices and have hallucinations of that sort. So just being mindful of knowing the individual's culture and religious background is super important. So now I'll talk about schizophrenia form. I can't say that correctly, but that's okay. So for this, this disorder is typically someone who is experiencing similar symptoms to schizophrenia. However, it is at least 1 month but less than 6 months, and the person with this disorder typically cannot tell what is real and what is imagined, and this can affect their behavior, emotional expressions, and interpersonal relationships, as well as other daily life, such as work, school. So again, for the diagnostic criteria for A, you have to have 2 or more of these for a long period of time during a 1-month duration, and you have to have at least one of the criteria for 1, 2, or 3. So delusions, hallucinations, disorganized speech, grossly disorganized, negative symptoms. Again, it's very similar to schizophrenia, but it's going to be less time. So, of course, for criteria C, you're going to have to rule out the schizoaffective disorder, depressive disorder, bipolar with psychotic tendencies, because they have to have no major depression or manic episodes within the active phase of symptoms. And the mood episodes have occurred within the active phase, then they would have to be the minority of the total time of the illness. And then, of course, criteria D, they have to be not attributed to substance use. You would then want to specify for these three things. So specify if it's with good prognostic features. So for this, it says that it requires the presence of at least two of the following. So 1, the onset of psychotic symptoms within 4 weeks of the first notable change in their typical behavior or functioning. And then they would have to have a premorbid social and occupational functioning. And they would have to have the absence of a flat affect. And then you would want to also specify if it was without good prognostic features. This would be applied if two or more of the above features have not been present. And then 3, for the specifier, you can also specify if it is with catatonia. And then the severity, which is again not necessary for diagnosis, can also be done from a 1 to 5 scale of how intense the symptoms are. I had a hard time trying to find some articles about the prevalence of this disorder because it is so closely related to schizophrenia. So if anyone has any articles that they find, I would love to read those after my presentation. Okay, so I just want to do a little disclaimer here. I'm going to do something pretty different for my presentation. I'm going to be playing an audio clip during the next slide. And it's a clip of what people might experience during auditory hallucinations. So if you feel uncomfortable with this, it is kind of intense. Please skip to the second schizophrenia slide. There's going to be a stop sign, and I'll also put a disclaimer at the beginning of my presentation, just as a title for this discussion, what the timestamp will be for you to just skip ahead if you want to. So this clip was mandatory for me to listen to when I was a mental health residential counselor. So we were expected to play this audio and go in to Walmart. We were expected to talk to at least 3 people, maybe buy something, look around a little bit. And this was a really hard experience for a lot of people. I ended up crying a little bit just because it is so overwhelming, and I cannot imagine living with this. So I just wanted everyone to be able to experience what I experienced. Maybe it'll give you a little bit of insight of what we're dealing with in the future as counselors. So I'm going to start the clip in just a second, so feel free to jump ahead to the timestamp or the stop sign, whichever one's easier. I don't know with this this program. All right. I guess I should kind of explain why I'm doing this clip. So obviously it's to give you awareness to what people might experience for hallucinations, auditory, but I also want you to try to concentrate on what I'm saying while also having these voices play. it's probably going to be difficult. So I'd love to hear people's feedback at the end of this discussion. Okay, so schizophrenia. This is on page 99 of the DSM-5. So for the diagnostic criteria, for criteria A, you have to have 2 or more of these symptoms for at least 1 month, and 1 or more must be 1, 2, or 3 of these symptoms. So as we've talked about a million, so this disturbance and a decreased level of functioning has to have 1 or more of these areas. So your work, personal relationships, and then self-care. So eating, sleeping, bathing, grooming, etc.
Remember that you humiliated it. You do, don't you? That's not trying.
And then for criteria C, you have to have this disturbance for at least 6 months.
Why are you trying?
And at least one of the month of symptoms may include predominant or residual symptoms.
Don't take your medicine.
The signs of disturbance may be present in the way of odd beliefs or unusual experiences that are perceived by you. And then you also want to rule out schizoaffective disorder and depressive or bipolar disorder.
Seriously, just stop.
So there's no major depression or manic episodes. And if they have occurred, then it would have to be the minority of the time. And then criteria E, the disturbance is not attributable to the psychological effects of substances. And then for criteria F, you also want to rule out autism spectrum disorder in childhood.
6, 5, 5, 4, 4, 6, 3.
Okay, that was rough. I couldn't even finish what I was saying because I was just so overwhelmed and distracted here. So I'm just going to go over schizophrenia one more time just so that I know everyone understood it. Obviously, I know that you guys have all read about it, but in case you either skipped the first slide or you just couldn't concentrate like me, I'm going to go over it one more time. Okay, so schizophrenia. The diagnostic criteria for A, you have to have 2 or more of these symptoms in a 1 month time frame. So 1 or more have to be at least 1, 2, or 3 on here. So we've talked about this a million times. These symptoms are very common between a lot of these disorders. So delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms. And then for criteria B, the disturbance has to have decreased the level of function in at least 1 or more areas of their life. So their work, interpersonal relationships, self-care. Self-care can be grooming, bathing, eating, sleeping, etc. And then for criteria C, they have to have continuous signs of this disturbance for at least 6 months. So this is the big diagnostic criteria for schizophrenia, is that it has to be at least 6 months. And for trying to catch my train of thought here. For some of this, it could include symptoms such as odd beliefs or unusual percepted experiences. And then for criteria D, we're going to rule out schizoaffective disorder, depressive disorders, and bipolar disorder. And if a person did have symptoms of these disorders, it would have to be a minority of the total duration. So it could not be during the whole duration of the illness. You're also going to rule out, for criteria E, rule out substance or other medical conditions. And then for F, if there's a history of autism spectrum disorder of a child onset, then this disorder would only be used to say that there is predominant delusions or hallucinations. So you also want to specify with this disorder. So you want to specify if it's the first episode and if it's currently an acute episode. So that means the first time, I guess, that the disorder came about, it would be the acute episode would be that they met the full criteria for this disorder. And this would obviously be during the first episode. And then for the first episode, you could also specify if it's in partial remission, which means that it only meets part of the criteria for this disorder. Then you could specify if it was first episode but in full remission, which means that they do not meet any of this, or their symptoms are not present. So none of the symptoms of this disorder are present at this time. Then you would specify if it's a multiple episode, which means that it has to be 2 episodes or more. And then you would do the same thing with acute episode, partial remission, or in full remission. You would also want to specify if it's with catatonia. You also can specify the severity of this disorder on, again, a 1 to 5 scale. But this is not necessary in order to have a diagnosis. So the prevalence, I feel, of schizophrenia is pretty high in the US. So more than 200,000 cases of schizophrenia happen per year. In children, it's pretty rare, but then after 14 years of age, it's very common. So typically people are diagnosed after age 14. A lot of the prevalence has to do with gender too. I believe most people who are diagnosed with schizophrenia are male. So in an article I read by Philip Gordwood in 1995, he said that schizophrenia is more diagnosed in males. It's about 1.4 times more frequently. And with that, he described that negative symptoms are more common in men, while positive symptoms are usually with females. So just to clarify, positive symptoms are usually added to the person, so hallucinations and delusions, whereas negative symptoms typically take away from the person. So inability to show emotions, difficulties talking, withdrawing from social situations and relationships. And then according to the DSM-5 on page 105, comorbidity with substance disorders is super high. So over half of people with this disorder use tobacco and smoke cigarettes on the daily. Anxiety disorders are definitely comorbid with this disorder. And then obsessive compulsive disorders, panic disorders are heightened with people with this disorder. So I just want to show you guys a video that I found very interesting. I actually follow her now because just hearing her story is super impactful, and I think that it will help a lot of people just understand or even just appreciate, I guess, a story from someone who is actually living life with schizoaffective disorder. Okay, so the next disorder that I'm going to talk about is schizoaffective disorder. For this disorder, it's typically a combination of symptoms of schizophrenia and a mood disorder, such as depression or bipolar disorder, and the symptoms may occur at the same time or at different times during the total duration of the illness. So for the diagnostic criteria, A is an uninterrupted period of illness when there is a major mood episode, such as major depression or a manic episode. And then also the criteria of A of schizophrenia. So again, delusions, hallucinations, disorganized speech or behavior, catatonic or disorganized behavior, and then negative symptoms. And then for criteria B, the delusions and hallucinations are at least 2 or more weeks, and they are absence of the major depression or depressive episode. And then for criteria C, for schizoaffective disorder, the person must meet the criteria for a major mood episode. Obviously, D, again, not attributed to substance use. And then you want to specify if it's bipolar type. So if there's a manic episode as part of this presentation, and then you want to specify if it's depressive type. So it only applies if there's a major depressive episode during the time of the illness. You also want to specify if it's with catatonia. And then these specific specifiers can be used after 1 year duration. So first episode, acute. This is the same thing that we did with some of the other disorders before. So first episode, acute. First episode, partial remission. First episode, full remission. And then the same thing for multiple episodes. And then you're going to specify if it is continuous, so the symptoms are completely fulfilled for the criteria for this disorder, and this is the majority of the duration of the illness. And then the same as the other disorders, you can specify the severity on a 1 to 5 scale, but this is again not necessary for diagnosing. So I found an article by William T. Reginold. I think that's how I'm saying his last name. And this is an article about the prevalence of type 2 diabetes with people who have bipolar disorder and schizoaffective disorder. I found this super interesting because while we don't treat diabetes, it's interesting to just see the interaction with this. Again, there's not a lot of research done, but this article came up and I found it pretty interesting, and I will link it below if anyone wants to read it. But it says that there are a few reports that there is an abnormal glucose metabolism in people who have these disorders. They found that diabetic patients tend to have a higher BMI, and people with this disorder tend to have higher use of psychotropic medications, which is associated with an onset of type 2 diabetes. I'm curious to see if anyone else finds any other articles about this, and I'm interested to hear your opinions on, obviously this is not a cause and effect, but maybe it's related. Who knows? So, throughout this whole presentation, everyone's like, what's catatonia? I guess I should have specified that at the beginning. But catatonia can occur with a bunch of disorders. So, there's neurodevelopmental, psychotic, bipolar disorder, depressive disorders, and etc. So during catatonia, a person may be required to be under supervision so that they don't harm themselves or other people. So making sure that they're eating healthy, they're sleeping correctly, they're not harming themselves. Some of the symptoms for catatonia can be mutism, so not talking. Don't know how to say this word, but stiffor. So no psychomotor activity, catalepsy. This would be a passive posture. It's a posture that doesn't really seem to be with gravity, if that makes any sense. I should post a picture to figure it out, but okay, so I just wanted to show some pictures of maybe what this would be talking about. So see the weird posture she's got here, and then this one here is just abnormal ways of movement, posture. Okay, so I'm not going to get too much in depth with the other specified schizophrenia. You guys can read it, but it's some symptoms without the others, with delusions with significant overlapping mood episodes, psychotic syndrome, symptoms are less severe and maintained well. Yep. All right, so let's go to our case study. I'm not going to go super in depth with this because I hope that you guys all read it before. But here's a little synopsis of John Evans. At the age of 15, he started showing symptoms of dysphoric mood, anhedonia, social isolation, panic attacks. He also had a sudden onset of palpitations. And then he now is a 25-year-old male. He had thoughts of that he was going to die. He was also smoking marijuana and drinking alcohol every day. And then after taking his medications, his severe depression would be lifted within a few weeks. At age 20, he had his first psychotic episode. He was hearing voices that he had killed someone when he was a child. And then he had hallucinations that voices were telling him this. He was completely convinced that he had done this. Then he had paranoia that people would punish him because he committed murder. He was hospitalized a few times because he wanted to kill himself. And then with meds, his symptoms remitted in 4 weeks. And during this time, he had major depression, 4 weeks out of the total 7 weeks of his episode. He was hospitalized again 2 more times. He had several weeks of delusions and hallucinations, and then severe depression that lasted another month. He had substance use, but it decreased after the episodes and stopped for a few months, but he still continued to have the symptoms. He is now sober and has been for 2 years. So now I'm going to get into my diagnosis. This was kind of hard because I was looking at schizophrenia first, but then I realized that he had the major depression. So I diagnosed him with So the diagnosis that I ended up giving John was schizoaffective disorder, depressive type, severe, multiple episodes, in full remission, 295.70. And this is found on page 106 in the DSM-5. So John met the criteria for A. He had uninterrupted period of illness and a major mood episode. And B, he had one or more with the symptoms of schizophrenia. He had delusions that he murdered someone and hallucinations that voices were telling him that he did this. C, the major depression lasted a majority of the time of the full illness. So D is what I was troubled with. So he did have substance use issues, but it did say that his symptoms continued when he was sober. So that's the conclusion that I came to. Let's talk about the treatment plan that I came up with. So the treatment of John would be based around his remission stage and relapse prevention. It's important for John that he has all the support that he can possibly get. For his treatment, he will be meeting with a counselor and medication manager in order to prevent a future relapse. The overall goal for John is to be able to understand his disorder and learn proper ways to better manage his symptoms without needing to be hospitalized again. He will attend counseling sessions once a week for about 4 months or more if needed. After John has gained the skills and knowledge and is able to continue in remission, John should have follow-up sessions in order to maintain this remission. So the sessions will be based around a person-centered theory, and the goal is to gain and maintain strong therapeutic alliance between the counselor and John, so that John is able to trust the counselor, and this will help him learn about his disorder in a psychoeducational manner. Through this, John will develop an idea of what his triggers are, stress that causes an episode. In order to find these triggers, the counselor will be practicing the cognitive behavioral modalities, as well as mindfulness and psychoeducational. So, the first goal for John would be John will report a decrease in depressive symptoms by at least 70%. The objectives, John will develop a positive sleep pattern. So sleep is super important for people with schizophrenia so that they can keep their mind steady and just be able to function a little bit better. So for this, I felt like John should find some coping skills that would help him fall asleep easier or even put him to sleep. So some of the examples of coping skills that he might be able to develop was drawing, coloring, reading, maybe listening to music, etc. The second objective would be John will develop an awareness of emotions and depressive symptoms. And this is helpful so that he can understand what symptoms he has and maybe how he can better cope with them. So in order to do this, journaling is so important. So he will keep a journal entry at least twice a week of his symptoms and emotions, and then he will also talk about those suppressed feelings during sessions. And then the third objective, John will learn ways to reduce depressive symptoms. As evidenced by, John will practice coping skills such as meditation and the ones listed above in order to decrease his depressive symptoms. So all of these would be considered cognitive behavioral therapy. I would also say a lot of psychoeducational, just because this is his process of learning about himself so that he can better cope. So the second goal for John would be to reduce his stress and gain social supports. So stress is said to be one of the biggest triggers for people with schizophrenia because when they're stressed out, they are most likely going to it's said that people with schizophrenia have a more sensitivity to stress. So John finding ways to limit his stress will most likely help him not relapse. So the first objective, John will identify social supports and increase spent time with them. So in the case study, it said that he was doing some isolation. So I feel like having as many people in his corner as possible is definitely going to help him so that he does not relapse. And I think his family or friends or any sort of social interaction will be good for him. So I said John will engage in social interaction face to face at least once a week. And John will identify and discuss common stressors and triggers for episodes. In this, John will journal stressors and triggers for his symptoms at least once a week, and then discuss those during sessions with his counselor. John will better manage stress in daily life. He will develop and implement coping skills to reduce the stress that causes an increase in symptoms. Now, these are all CBT and psychoeducational, lasting anywhere from 2 to 4 months. And his third goal, John will decrease response to hallucinations and delusions at least 50% of the time. And I believe that the response to the hallucinations and delusions is important because some people can't really stop the hallucinations and delusions, but if they can better cope with them and live with them, that's probably the main goal. So, objectives. John will decrease intrusive thoughts. He will use mindfulness coping skills and challenge his beliefs. And for that, he would be challenging the origin of the intrusive thoughts. So I would be, or the counselor would be working with John to figure out a way that he can better understand his delusions. So his delusion mostly was that he killed someone when he was a child. So finding a way for him to understand how likely is this to be true. Does your family believe that you did this? Is there any proof that you did this? Etc. So John will challenge delusions during his daily living. He will again challenge irrational ideas and write them down. So I found that if he wrote them down, he would be able to better be aware of his thoughts and start to manage and think about how likely these thoughts are to be true. John will develop and implement coping skills to ground himself during hallucinations. So he would use mindfulness and CBT to implement breathing techniques in order to ground himself and become more aware of his surroundings. So not only could he use the breathing techniques to just be aware of his body, like I'm here right now, this is where I'm sitting, this is what's happening to me, but he could also do some meditation. So just being aware of his thoughts. Okay, this thought's coming into my brain. I'm going to acknowledge it, but then I'm going to let it go. So with therapy, it's recommended that John meet with a medication manager because medication is known to be very effective or helpful, I guess, with people with schizophrenia or schizoaffective disorder. I guess I kept saying schizophrenia, but schizoaffective disorder. So he would be meeting with a medication manager on a regular basis in order to make sure he is taking his medications, but also taking medications that are supposed to work and make his symptoms more manageable. Another suggestion for John is for maybe his family and him to attend a group therapy. And even if they're not having trouble per se, I think this might just strengthen John's natural supports to be able to help himself. I also recommend that John continue to attend groups or counseling for his substance use just to prevent future relapse. So I hope you guys liked my presentation. It was kind of choppy trying to figure out this whole, what is it called? Screencast-o-matic. So sorry about all of the stopping and going, but I found this very interesting to do because I don't have a whole lot of experience working with people who have schizoaffective disorder or schizophrenia for that matter, so trying to figure out what I was going to do for his treatment plan was kind of difficult just because I'm not used to working with that population. So I'd be super excited to hear people's feedbacks, maybe some ideas of what you might do for a treatment plan. Obviously, I'm not expecting you to make one, but just some ideas would be so helpful because this is important for my career, everyone else's career. So, thanks everyone for listening. Definitely check out the YouTube videos that I put in here because she has some really good stories to tell. And I hope everyone enjoyed the clip that I played of the auditory hallucinations. That was pretty intense. Alright, I'll stop talking now. Thanks, guys. Oh, and just so everyone knows, here's my references. I will post some articles with this as well that you guys can check out. I know I talked about a few of them. They're pretty interesting, so I'll let you guys click on them. Thanks.